So welcome to the Enhancing Clinical Practice and Outcomes stream at the SNOMED Expo 2025. I'd like to thank FAST for sponsoring this stream. My name is Ian Green. I'm the Global Clinical Engagement Lead at SNOMED International, and I'll be your moderator for today's sessions. We'll address all the questions at the end of the presentation. If you're online, just please use the Q&A button to submit your questions to the presenter. And for all those attending in person, feel free to use the microphone that's provided in the middle of the room. It's now my pleasure to introduce, I hope I pronounced this right, Francois Kaag. Excellent. And I definitely know from CIADEM and Peter Groves Williams, I know I pronounced that correctly because I work with them, from SNOMED International, and they'll be presenting on the NUVA vaccine ontology extension to SNOMED CT. So Francois, Peter, over to you.
Thank you. Is it on? Okay. So this is to present the work we have done over the last 2 years, I would say, with Peter and many others about the NUVA vaccine ontology extension to SNOMED. Originally, NUVA, standing for Nomenclature Unifiée des Vaccins, Unified Nomenclature of Vaccines, was designed by CIADEM a very long time ago. It has been around since 2009. And our purpose was to feed a clinical decision system for vaccination. So the idea was that we needed to capture the whole history of vaccines administered to a person, knowing that we have to go very far back in time. Vaccines that were administered 60 or 70 years ago are still relevant. And we need to go anywhere in the world. People do travel, and they may have received vaccine in Uruguay and then travel to France. So this is where it came from. And incidentally, we were part between 2020 and 2022 of a project for the European Commission to study the feasibility for a European vaccination card. And one of the surprising points that we discovered when building up this project was that there was a real issue with coding of historical vaccines. Every country has its own way of coding, every country has its own code system, and there was absolutely no way to reconcile them that was commonly accepted. And we realized that what we had used for our own purpose of clinical decision support was something that could perfectly be valuable to reconcile these fragmented descriptions of administered vaccines. So this is why we took the decision to propose this NUVA unified nomenclature as a common good. And this decision was taken after the European projects in 2022. So basically, the NUVA ontology is a very simple one. If you look at this diagram, on the right-hand side, you have got the functional description of the vaccine concept. A vaccine contains a number of valences. Valences are the functional units of a vaccine that are addressing specific diseases. Why do we need this notion of valence? Because we have many and more multivalent vaccines that do serve a number of different diseases. The classical one like diphtheria, tetanus, polio, but now we've got pentavalent, hexavalent vaccines of many sources. And on the left-hand side, you've got the part that is more about alignment and how do we convert from records that do exist in other code systems. Other code systems could be national pharmaceutical codes, could be a global code like SNOMED or ETC, could be a number of different codifications. The idea was really to be able to capture anything that came in. And so anything that came in originally, back in 2009, was mostly written records. we had paper vaccination cards, and we wanted to capture information from these. And the information that was written there could be exact, could be misspelled, could be abbreviated. So we had to take into account all of these possible variants. And then progressively, through the time, through the years, we saw more and more digital sources and started to also have to cope with these external codes and align external codes. So this applies to vaccines that are totally characterized. We know exactly what product, what real-life product was administered. This could apply to functional descriptions of vaccines, such as Tdap, that some vaccines against tetanus, diphtheria, and pertussis. Or this could be even vaguer, especially when you look at very old vaccination records. He has received some vaccine against flu. So all of these levels of descriptions we wanted to capture, and to capture without losing precision. Now, if I come back to the right-hand side, the part about the functional description, as I said, the functional description is about valences. And this is where we had to introduce some more subtlety, because this functional description is also something that can be more or less precise. So if I take the example of a pertussis vaccine, we could know that it's some pertussis vaccine, whatever, or it could be a cellular pertussis vaccine or a whole cell pertussis vaccine. And in that case, the vaccination scheme that you have to apply is different. The strategy is different. So we need to make this differentiation for our clinical decision. And among the acellular pertussis, you've got the pediatric dose and you've got the adult dose. And this is different again. So valences are here to represent the functional role of a given vaccine against a given disease. It's a notion that is used very currently by vaccinologists. Still, it's a very pragmatic notion, meaning that we are not trying to capture every teeny detail. We don't want to know all the strains of a given infectious agent that we are addressing if there is not a vaccine that corresponds to that. But this functional description and having this hierarchical functional description is something that is extremely useful when trying to process the vaccine code, not only for the purpose of clinical decision, but also for the purpose of aligning external codes that corresponds to different level of granularity. We can, by navigating through the valences of a given vaccine, convert from a fully specified product to a generic product, or the reverse way, even if they are not described at the same level of precision. So as I said, in 2022 is when we decided that what we had devised so far was of interest for the community. And we presented this at the Low-Inc International Conference at the end of that year. And it happened that Rory Davidson from SNOMED was present and just hopped on me after the presentation and told me, what you've done is quite interesting, we could do something. So we could do something, turned it to action. The next year, we onboarded slowly. We presented what we had done to the drug extension user support group, and we had to go further. We had informal agreement from SNOMED that we were about to do this. We started to navigate a bit about functional alignment, and 2024 was really the year where we actually worked. So we worked on the not so funny part about contracts, and we worked on the funny part about technical alignment. And it was funny, but it was not so easy because we were coming from very different sides. As you have understood, our NUVA model originally was not designed with terminology in mind. It was really from the field and practical use. And it took a while to understand each other. But finally, we did it. We had a good working draft by the end of 24 and made the formal release in May 25 this year. We had a launch conference in May in Bordeaux, and I'm presenting today to also to introduce you with this new NUVA extension. So what was interesting, what was good was that basically we had the same purpose, the same way of thinking globally, and the idea of really modeling knowledge. There was a very good idea from the SNOMED team that was to pre-compute the functional tree of the vaccines, while on our usual way of working, we did it on the fly by processing the valences. So this is something that is interesting, and hopefully we will also introduce it into the core NUVA. What was more painful from my side, and after that I will let Pete explain the SNOMED tooling and processes. You know this perfectly. You have lived with this for decades. We don't. Quality checks and a lot of hidden assumptions here, or if they have written something, I didn't find them. The fact that we identified vaccines with concrete vaccines with brand names, and brand name is very far from being a fully qualified name. We had long debates about the difference between a valence as a function and an ingredient as a substance. And we paid the price for our origin. That was really helping humans to enter information, meaning that we were not very strict about the way we named the concept, especially for the abstract vaccines. And the SNOMED people, they are very, very strict about naming.
Thank you, Francois. This is actually the first time that Francois and I've seen each other since we worked together in May at the launch event. Susie was there as well in Bordeaux. We're missing Dr. Jim Case as well. He was the person that was going head-to-head with Francois on the difference between valence and ingredient. I just had to wait for the dust to settle and then do whatever it was they'd told me to do. So why did we do this project? This was part of one of the strategic objectives for SNOMED CT to become a hub for integration of different code systems, to make things simpler to use, to make it quicker for implementers so they don't have to use a new format. NUVA actually releases as a single ontology file. It was quite a nice thing, rather than a lot of old systems use CSV files and so on have to load them. So that was really cutting edge technology we got to play with there. Because vaccines at the branded level are missing, well, we made the choice not to put them into SNOMED CT. So in the medicinal product hierarchy, we have an abstract level of drugs, which is fine because those can be ordered. You say 500 milligram paracetamol tablet, you don't need to know if that's Panadol or some other brand name. But in this use case, it is important what the brand, when you're recording that a vaccine has been given, it is important the name of the vaccine. And NUVA is tracking that across the world. And so that is content that we can really benefit from. So yes, we got a lot out of it. And I'll show you that in the next slide where we get onto the hierarchy that falls out. But SNOMED's validation routines have grown organically over time. We run 1,000 tests when we check something. So inevitably, when another code system comes in and gets transformed, it gets exposed to sort of questioning that they haven't seen before. And it's a lot of fun to work together. We just have a great time doing this. Although, you know, as Francois said, it's not easy. So the NUVA extension is a module. It's an extension of a particular version of the international edition. All of the active vaccines are children of the vaccine product. They don't classify super nicely with our content at the moment, and that's something we'll be looking at in the future. So each NUVA concept gets expressed. We say it's exactly the same thing. It's the same entity, just been expressed in a new format. It gets a SNOMED CT identifier, but it also retains its original code as an alternate identifier. And Francois mentioned what happens in classification. We'll get onto that. So NUVA describes a hierarchy in its valences. And what happens, so those become SNOMED CT concepts as well. They then inform a hierarchy in the vaccines. And so you can see this is how they drop out. So the trivalent and the tetravalent vaccines come underneath the products with fewer ingredients. So this was another area of validation, because if the valence had been given incorrectly, then it will appear at the wrong place in the hierarchy. So we could suddenly see that a measles vaccine was a type of avian flu vaccine. And I would say to Francois, what happened here? And the turnaround time is incredible. They release perhaps daily their product. They are so quick to turn that around. It's so we had we improved quality with very quick iterations there. Transformation process, well, this is what I live and breathe. So this was really nice to do. This was actually the third transformation that we'd done. So we started with LOINC, then NPU, and a lot of that code had already been written. So 80% of what we needed was already there. And so there was a lot of reuse going on. Vaccines and valences both go over. The abstract vaccines form the hierarchy. And then in fact, it was a little confusing, but in fact, the concrete drugs, the concrete vaccines that have brand names, they end up being primitive because they have exactly the same model as their parents. There's no difference in the modeling. So you have to make them primitive because the only difference actually is in the name, which isn't something that appears in the model. So that process runs through. Currently it runs on my laptop, but eventually we'll evolve to having it run perhaps daily on some server there, and it will form the model in memory, and then it will look at what's in our authoring platform and say, what changes do I need to make to bring this into line with what has just been calculated? And we get out a processing report, so we don't have to go into the authoring platform and check on a concept by concept basis. We get a spreadsheet out, which is quite easy to eyeball. And something that's very gratifying about this work is that unlike LOINC, where we are taking a long time to get to a map that will allow us to put every LOINC concept through, we've done 100% of NUVA here because the model was straightforward. So every valence becomes a concept, every vaccine becomes a concept. We've got all of their content. So we look forward to getting the next edition through at some point. Just checking my time here. I said that active vaccines classify under the equivalent concept in SNOMED. Something that we noticed quite late in the day is that NUVA also includes passive vaccines, where we're not stimulating the body's immune system. You're taking in antibodies in an existing format. And those appeared in the wrong place. We had to quickly identify them, which Francois was able to give us pointers on how to do that. And those are sort of just manually, not manually, in the code, we say, put those over here so they become a product containing immunoglobulin. But still, the valences cause the hierarchy to form quite nicely underneath that. So there you see the collision of the two systems. So the has valence is coming through from the NUVA concept. The has active ingredient attribute there is being inherited because it is a product containing immunoglobulin. And this is perhaps where we're going to see some alignment in the future, as these two models could perhaps work together. And you can see there that the SNOMED identifier is where we'd expect it to be, and also the alternate code for the NUVA code identifier. So now that we're working in a SNOMED CT format, we can leverage the power of SNOMED CT in expression constraint language, ECL, and we can ask questions that just weren't possible to be asked in the original product. So we can ask for all concepts that have gone into this new module, just look at the vaccine products, show me all the valences, and then we can pull out those passive vaccines as well. If I run those through, I can, in the browser, I can see those results come out. And that one there is a filter for tetanus. So how many did we have? It was in the full set of vaccines. It was 2,000? 1,500. So if you filter that down on just the tetanus vaccines, you're just about 300 of those that get found. And this is really where I wanted to get to with this work, is that now then allows us to transmit messages that use both codes in a transparently interoperable way. So if your system works with NUVA, continue to use the NUVA code. If you are a SNOMED CT site, then you can use the new code. And Francois, it's his product, so I'll let him have the last word.
Okay. So, as I said, we've worked quite intensively for a first step that was what was just presented with the vaccine and valences concepts included. We have other assets in NUVA that are not yet fully onboarded or not onboarded at all. The one about alignments with many other code systems, and that one I think is very valuable in the role of SNOMED as a pivot terminology. And we have also the translations of the descriptions when the vaccines are not characterized with a brand name, where we also have set up a process, and we have already several translations because we have projects running in several countries in Europe. So all of this, we have to find how we will integrate it. We have to integrate better the production tooling. So we are doing on our side with also new structure, new production tool, and delivering this on GitHub so that everybody can also track the changes across NUVA versions. And it would be quite easy starting from there to trigger automatically SNOMED ingestion, because as Peter said, the transformation from NUVA to SNOMED does not require manual intervention. And similarly, we now have reintegrated the newly created SNOMED code for the NUVA vaccines in NUVA, but this loop has to be done systematically each time we will ingest a new NUVA version. So that's on the technical side. And on the operational side, we are working to make this NUVA common good more robust in terms of organization, not depending only on the CIADM company. And this is through the International Vaccine Code Initiative that we have launched with the help of the American Immunization Registry Association. We have a working group meeting once a month with experts in vaccine codification, working on NUVA, but not only on NUVA. The NUVA is rather some kind of common lingo, common tool that is here to bring value to this group. But the idea is also to be able to create really collaboration across members. And finally, some tooling for any contributors.
Okay. So thank you, Francois and Peter. We'll now begin questions. Obviously, if you're online, please put them in the Q&A and I'll ask them for you. If you're in the room, please use the microphone, ask your questions. So over to you as the audience. Okay, that's quick. Yeah, use a bit.
I just wanted to know in NUVA, do you have details of the adjuvants used for vaccines? The adjuvants, so the excipients that are used to increase the immune response but aren't bacterial?
No, we don't. The idea of NUVA is really to focus on one single use case. It's keeping the long-term vaccination history of a person. Adjuvants are relevant, especially for adverse events, and this is short-term. So we did not want it to onboard this in NUVA, and we don't want to onboard in NUVA anything that is general to any medicine, because it's certainly addressed by someone else in the general field of medicines.
Thank you. It was a good presentation. For those countries that have in their extension vaccine content, is there a linkage we need to do? How would that work?
Yeah, the idea is to create alignments of any local vaccine code to NUVA, knowing that through this alignment, then you are able to align with any other one that is also aligned to NUVA. That is for every external code in our terminology. So any code existing in a code system, there is one and only one corresponding NUVA concept. And if you want to navigate from your national code to some other national code, for example, either you have a direct jump through the NUVA concept, or if the two codes are not at the same level of granularity, then you will have to navigate through the valence tree to find the best possible equivalent. So we have implemented a few scripts that are able to do this. And with every NUVA version, we already release versions of the best possible code in code X, code Y, and so on.
Thank you. Any other questions? Okay, so in which case then that concludes this session. To our online delegates, you're welcome to remain here for the next presentation in the stream, or if you navigate to another session via the event lobby. And thank you, Francois and Peter, for an excellent presentation. Thank you.